Everyone for Uromet 19. So shall we move on to the first candidate, Dr. Nishanta Veerasinghe, and I think Dr. Manjula Herath will be the examiner.
Hello, Nishanta.
Good evening, sir.
Good evening, Nishanta. This is the first case. I don't have any slide to share. I will present the case, then you need to go ahead, right? So,
Okay,
56-year-old male presented with PSA 3.9 and repeated after 3 weeks, it came as 4. After consultation with this patient, he agreed to proceed with multiparametric MRI of the prostate. Okay.
Yeah.
So before requesting made your request to radiologist, what are the things you concern or information you gather from this patient about MRI?
Yeah, for the MRI special preparation needed, I would like to ask whether there is any metal devices inside, any intracranial clips and ocular implants, any dentures, whether there is a renal failure, diabetes, and then whether the patient is having claustrophobia. Those things I would ask and document, and if there is any clips and things, any surgical surgery is done, when was done, and what are the
patient
what type of clips.
Yeah, okay, Nishanta. Patient want to know why he should undergo this test.
Because it has shown in recent trials that pre-biopsy MRI has significantly improved the chance of picking clinically significant prostate cancer. Such trials are MRI first, one of the MRI first thing.
Okay, so are you going to discuss further about any necessity and issues related to that doing MRI?
So I would say that MRI.
Yes, whether after MRI, whether you can confirm whether I have cancer or not.
No, MRI cannot confirm. It's a gold standard test for confirmation is a biopsy. That also has some negative aspect, but MRI can specifically identify whether there is any clinically significant cancers and the pyrite version is less than 3, then we can safely, and if the other risk factors also less, then we can safely omit biopsy, which has its own complications.
Okay, so what type of machine you prefer and any specification for those machines, MRI?
3 Tesla machine is preferable because it has a high resolution, but if we have only 1.5, need a rectal coil to improve the resolution. Yeah.
Okay. So what are the sequence of images you are going to obtain during the prostate imaging?
Mainly 4 types: T1 sequence, T2 sequence, contrast enhanced image, and diffusion weight images.
So can you explain a bit more?
So T1 sequence is when the MRI doing when the application of the magnetic field, the hydrogen atoms in the body water align in a longitudinal direction, and when the radio frequency is applied, they align into the horizontal direction, and then once the transient radio frequency energy withdrawn, that they revert back to the longitudinal position and emit radiation. That phase was T1. That's more anatomical.
Nishanta, T1, what are the information you are going to gather? T1 phase.
T1 phase more anatomical, and T2 the functional aspect, and contrast enhanced. Then we can see the metabolically active areas.
T2 image, what are the information you are going to gather? T2 image.
In T2 image, the prostate, I would see whether there is any dark areas and the black areas in especially the peripheral zone as well as in the other zones. Those dark areas is significant, and then compare with the other the contrast enhanced and diffusion weighted imaging to see whether it is significant.
So what are the various the two images in diffusion weighted image? Two images we take. DW1.
I can't remember now. There is two. Yes.
Yeah, okay. So what is the importance of contrast, dynamic contrast images?
In contrast images that will specifically show if the metabolically active tissue and more prominent the dark color, white color lesion on the contrast image.
Okay, what is the contrast we use for contrast imaging?
In MRI, we use the gadolinium-based contrast.
Okay, and so do we need to do contrast images for all the cases for interpreting?
It may not be necessary, but if we use it, will improve the sensitivity.
Okay, so okay, what are the MRI's sequence incorporated in PIRATES 2? You have mentioned when you
PIRATE version. Yeah.
What are the MRI sequence they consider?
MRI T2,
Yeah.
and dynamic contrast enhanced and diffusion weight imaging.
Yeah, okay. So male, okay, we'll discuss later. Then can you explain PIRATE V2 version grading system and importance?
There is 5 gradings. So grading grade 4 and 5 is more suggestive of malignancy. And grade 3 is equivocal, and grade 1 and 2 are benign.
Okay, so what are the additional information you can gather by doing prostate MRI in case of prostatic malignancy?
Additional information is we can suggest whether there is any the prostate size first, and then whether there is any prostate cancer invasion to the local tissues, whether seminal vesicle involvement or dilatation, or other benign pathology.
No, in case of prostate cancer, what other additional information? One thing you are going to see whether prostate cancer is there in the prostate or not, and the stage, and what other additional information?
The volume of the prostate cancer, local invasion, seminal vesicle invasion, and then
local regional?
Local regional. And lymph node also, if the pelvis also involved, then we can comment on the lymph node as well.
What else? Okay. So then this patient, what is the importance of knowing prostate volume when you do MRI? Prostate volume.
Prostate volume is important. Couple of things. One thing is for calculation of the PSA density. Other thing is when deciding the treatment options.
Time's up.
Okay. Shall we go ahead? Yeah, good. Actually, this is a bit difficult topic, I know. That's why I put, because I will share a video which contain some descriptions. The main thing is you have to, Nishant told a lot of information about preparation, but you have to mention serum creatinine, because the creatinine is important. Otherwise, the complication that they are worried about, the post procedure complications. The creatinine is very important. And yes, you have mentioned a lot of things about that. The only thing you have to say the patient, if you undergone MRI, that this test alone, we can't 100% rule out prostate cancer, but we are trying to identify the patient with high volume, high grade disease with significant sensitivity and specificity. But we can't completely rule out by doing MRI. Normal MRI can't exclude he doesn't have significant cancer. And then the T1, T2, TW. T1 is important, especially post-biopsy patients, because hemorrhagic area look white, and then the hemorrhagic area in T2 image looks dark. So to differentiate that, T1 image is very important, as well as during infection. And T2 images, the prostatic malignancy, especially in peripheral area, look dark in white background. And you can, as he mentioned, you can identify whether there's an extension beyond the capsule and the seminal vesicle involvement, those things. And the BPH mainly heterogeneous, and sometimes difficult to identify the malignant area in the center of the gland. And so a patient with the prostatitis also you can see, but sometimes it look like wedge area rather than the spherical lesion. Difficulties come. And DW has two imaging mode. One is high DW in high B value, at least 2000, where you can see as a white area in malignancy, and then ADC map, that is also reconstruction, where it look as a dark area. Then dynamic contrast images, mainly they look for the early enhancement and early washout. And this contrast image is not taken for the pyrus grading assessment, but it helps for the ultimately when they give the pyrus grading. And the other thing is they did MRI spectroscopy, but they don't do, because it's a time consuming and operator dependence, and they don't do that for the current MRI protocols. And then pyrite system 1 to 5, highly unlikely pyrite 1, unlikely pyrite 2, equivocal 0, 3, and 4 likely and highly likely 5. And the lymph nodes and bone mets we can see. And prostate volume is important, because sometimes especially when this pyrite 2 lesion or something comes, the prostatic the PSA density is important, and various centers take different density parameters. 0.12 as some centers 0.15 prior to consider biopsy options. And then the other one, actually I prepared but I couldn't go ahead. This patient found to have a lymph node in pelvis. And so what is the most suitable single lymph nodes, because he has low PSA grade, but lesion came as pyrite 5, localized lesion within the prostate. Then it's a single lymph node in the pelvis, doubtful lesion. So then in that case we can do PSMA PET, yeah, and see whether what sort of lesion it is. And but PSMA PET mainly they do for the biochemical recurrence detection after radical treatment. The sensitivity depends on the PSA level. Low PSA, the sensitivity is not that good, but when the PSA levels are high, the sensitivity is more. And then one more thing regarding prostate imaging, you have to know about the bone scan, and doubtful bone scan lesion, then you need to do MRI. Okay.
Thank you,
I
sir.
think, Nishant, the other thing, what is the significance of knowing creatinine for the MRI? What is the complication?
The systemic fibrosis, nephrogenic systemic fibrosis. So if it is less than 30, we should go ahead with the gadolinium contrast.
Right. And the other thing, Dr. Manjula asked about the information, the additional thing you need to tell, you can get some limited information about the pelvic bones if you do the prostate and the pelvis.
Okay.
Thank you, sir.
What is the mark, Ranga? You can
GFR is less than 30 or less than 60, just to make sure. Book says 60. Is that, am I correct, or correct me if I'm wrong?
Gobi, any idea?
Dr. Gobi, you're muted.
Okay.
Yeah, book says is 60. So yeah, but more than 30, you have a more risk of developing NSF. But risk factor is EGFR less than 60. And few other thing is it MRI scan is safe in pregnancy? Nishant?
Yes.
Whole trimester? Can you use MRI scan in the first trimester?
No idea. Maybe not.
Yeah, so we don't know the unknown effect of MRI scan in the fetus, especially in the first trimester. So people are reluctant to use MRI scan in the first trimester. But there's no well-known documented effects, but people are reluctant to use. The other question I want to ask, what are the other places in urology we use MRI scan other than the prostate cancer?
Yeah, that's a
And
good one.
kidney, if there is any so RCC with IVC thrombus, there is a place for MRI in that case. And as as small renal masses is fat poor AML. In that case also there is a place for MRI.
Indeterminate renal mass. Yes, that's a renal cancer with the indeterminate renal
And the
mass. So
pen-
if you just
and the
suspect
penis.
extension of thrombus behind the liver, so if you want to see the extension, yes.
Yeah, penile cancer.
Yes.
Okay, in the penile cancer, what kind of MRI you will do? How will you do the MRI scan?
MRI with artificial erection.
So what you will give for artificial erection?
Triurethral alprostadil or the intracavernosal alprostadil.
Yeah, so Cavijet, isn't it? Yeah, in the right. Okay, so we use in penile cancer staging, we use in indeterminate renal cancer, and of course retrohepatic thrombus. Where else?
It can also use the delayed presentation of priapism sometimes.
Okay,
And
if you want to check the fibrosis is established or not.
yeah.
You can do the MRI penis. Yes, bladder cancer.
Yes, I was about to ask. Is there
Yeah,
any
the
place in bladder
staging
cancer?
T2. Yeah, so staging T2
Yeah.
stages. But
To
if
say
it is
whether
beyond
T1
T2,
or
then
yeah.
sorry, if it is
To
beyond
say
T2,
whether-
then MRI and CT both equivocal. Sorry,
Yeah.
similar. But for T2, yes.
Then and also stone in pregnancy. You can do MRI urography. In MRI urography in pregnancy, do we have to give contrast?
No, because the
No.
urine will let that's a contrast there.
Other thing,
Then-
penile fracture. Penile
Penile.
fracture. Yeah, if it is difficult to diagnose, you do MRI.
And the adrenal tumors also we can use the MRI.
Okay, in case of stone, in MRI urography, how will you visualize the stone? How it will be?
It will be look as a filling defect.
Very
The
good. So
stone
that's
cannot
known
be
as
seen. Yeah.
signal void. Signal void.
void.
You won't see any intensity. Then sometimes they will ask in MRI scan, we know T1 and T2, what is STIR? They asked me, I don't know, it's basically T2 with fat suppression. That's mean, no, you will see only the water containing stuff. That is known as STIR. There's one STIR, other one is FLAIR. That is FLAIR means T2 with water suppression. STIR means they ask about STIR. That's a T2 with fat suppression. Yeah, that's all I want to. Yeah.
Thank you.
Dr. Angal, you want to tell some more things?
No, basically you have covered. I just wanted to add about the bones and things you have already and bladder cancer part.
Okay. Thank you. I think we can move to the next scenario.
Yeah.
Tilina?
I think Dr. Ranga will be examining, and
I think
I'm
Dr.
present
Nalini is
the
having a little bit
cases.
of connection. So we'll move on to
Tina.
Dr. Hillary. Sorry.
yeah, all the cases will be asked by Dr. Manjula here.
Manju.
All right. Okay.
And
Because, it's Dr. Manju who kindly prepared all the cases.
All right. Okay.
Dr. Ranga will be the co-examiner and give the feedbacks and
All right.
inputs.
Okay. Right. So I think
This Hillary.
Dr. Hillary will be the candidate, I think.
Hello, Hillary.
Hello. Hello. Good
Hello.
evening. Can you hear me? Hello.
Hello, Hillary. I'm here. Okay.
Yeah.
So
I'm having a bit of trouble with the internet. I hope you can hear me. Hello?
Yeah, I can hear. I think if you can't, if you have a trouble, you switch off your video. Switch off your video, then the sound quality will be more. Okay.
Okay.
Hillary, the next one is 38-year-old A1 businessman who frequently travel abroad for his business work, presented with right ureteric colic. Non-contrast CT KUB was done and 7 millimeter right upper ureteric stone and 6 millimeter lower pole stone, same side, with mild hydronephrosis hydrolated. So what are the other information you require to manage this patient?
I will I need the further assessment into his renal function, whether he's the current renal function, whether there are any inflammatory markers, fever, or any other thing, or any other comorbidities like diabetes or immunodeficiencies, like HIV, immunosuppressant medications. So those things are required in the history, and in the examination, I'll see whether the patient is having fever, whether the right renal angle tendency is there. Features for acute intervention, and this is a patient who is traveling frequently overseas, and might as well think about complete clearance if the patient does not have any evidence of infection and inflammation.
Okay, so regarding his CT scan already done, what are the additional information you want to gather?
So
non-contrast CT he has undergone?
Yeah, whether there is any fat stranding around the ureter and the kidney, that will tell me whether there is acute inflammation going on, and whether the opposite kidney is normal, and the Hounsfield units, number of Hounsfield units, that will tell me about the density of the stones, and
okay,
and the reconstructed image, if I can get it. Yeah.
Okay, so what are the other imaging modalities we do with patient with ureteric colic?
The common ones are the ultrasound scan to begin with, to look for hydronephrosis, hydroureter, and the X-ray. That will again tell me whether this is a radiolucent or radio-opaque stone. That information can be gathered from the initial scan of the CT scan as well. If the stone is visible on that initial scan on the non-contrast CT, then the stone is also radio-opaque. And then the IBU.
Hilary, regarding ultrasound scan, what are the information you gather in respect to stones?
Yeah, so any acute inflammation, any features of pyelonephritis, the fat stranding around the kidney and the bladder and the ureter related to the stone infection site, whether there is any fluid extravasation, perinephric fluid.
Okay.
Yeah.
What is low dose CT?
Yeah, low dose CT utilizes a minimum amount of radiation compared to the standard KUB, and that is okay for non-obese patients. The low dose CT is not very good for obese gentlemen, and that will not give me much information about the other pathologies that the normal CT would delineate.
And is there any place for CT urogram for stone disease?
CT urogram is useful. That will give me the detailed calyceal anatomy, because this patient has a lower calyceal stone as well, which is 6 millimeter, and because he's a frequent traveler, and I might use pushback and PCNL to achieve complete clearance. In that case, it will be useful as well. But then the radiation dose is great. The same detail I might be able to gather.
Yeah. How do you going to manage this patient in the acute stage? If he comes with acute colic,
inflammation. Yeah. So the first thing is to relieve the pain, and I can do that with non-steroid anti-inflammatory agents, or opioid analgesics like morphine or methadone with antiemetic. And then see whether there are any features of infection or inflammation is there. Send urine for MCS and bloods for full blood count, CRP, and creatinines. And then the basic imaging. And once the pain is settled, now this is there is a 7 millimeter stone, and although the evidences are not not very conclusive, I can still use the medical expansion therapy with alpha blockers as well. And EAU guidelines suggest we might use medical expansion therapy for stones more than 5 millimeters.
What are the other options for him?
Then for the upper ureteric stones, especially if the stone density is suitable, less than 1,000 Hounsfield units, the extracorporeal shockwave lithotripsy is one of the options. And even for the lower calyceal stone, there's an option if the infundibular pelvic angle is suitable and the calyceal width, the calcial neck width is more than 0.5 and less than 3 centimeter length. And so
this patient's CRP came as 65 and he had loin tenderness. So what is your plan next?
So this patient has signs of acute inflammation. So it is the most important thing is to sort of like arrange source control and to put a stent. And this is a upper ureteric stone. So I think might be able to put a stent without much trouble. And the other option is a percutaneous nephrostomy. Sorry about that. And
any other things you do if you suspect infection?
The antibiotics, broad spectrum antibiotics.
Okay. Okay. So
Time is up.
Okay. So actually, this topic has many topics. Things. So I put the first part to the Hillary. Yes, Hillary, good. And you mentioned about evaluation of the patient and especially the creatinine and CRP, if you're suspecting infection only, CRP. And the CT, yes, imaging density, location of the stone, and ferronephric fat stranding, you can collect, and the enlarged kidney and suggestive of infection sometimes. And those things you can gather, and you can see any renal anomalies and contralateral kidney. The ultrasounds KUB, yes, you can see the stone, evidence of stone within the kidney, and you can sometimes you can trace the stone ureter down to the stone where it's lodged, and you can see the upper ureter and lower ureter if it's dilated, and if the full bladder, you can assess the lower ureter, and so you can see any extravasation around the kidney after calyceal rupture, which indicate high grade of obstruction. And some people assess ureteric jet, which is with doubt about the significance, because the normal kidney also sometimes not produce ureteric jet equally all the time. And those are important. And then the CT, low dose CT, the issue is you can't see any other pathology correctly, and sometimes you might miss small stones, less than 3 millimeters small stone, you might miss low dose CT. And but it is comparable to radiation dose to X-ray KUB. And the doing X-ray KUB advantage is you can see the radiolucent stone. I mean, you can see whether there are any radiolucent stones, which might inform for further management in future. And CT urogram will add some functional components to the study, because whether there's kidneys excreting or whether it's a significant obstruction. And the acute stage management, yes, pain relief, the NSAID is the first drugs we use, but sometimes we have to concern about patient with heart failure, patient with renal failure, AKI, we have to be worried about. In cardiac patients, we have to worried about.
And NSAIDs allergy, you need to mention.
Allergies, and then other thing is you can use morphine and not to use pethidine. Better to use morphine or tramadol if you suspect ureteric colic. And then the surgical pain relief is decompression if you can't do acute and primary surgery at the same time. And you have to look for hydration, and these patients are vomiting and dehydrated, ill. You have to look those parts as well. And medical expulsive therapy, yes, you talk about, and a bit I want to add, because the new urology guideline says if it is radiolucent stone, you can ask alkalinization agent to the medical expulsive therapy, more than 5 millimeter. So, okay, so because I will leave the other part to the next topic. Okay.
So other questions you are going to ask with the next case or what?
Next person.
Okay.
Is that okay, or we'll go for a different one?
Yeah. No, these are very important things you have. You have definitely covered those next two topics. Yeah.
Okay.
Sir, that alkalization is this for ureteric stone or renal stone?
Yeah,
Sir?
your guidelines, the latest guidelines say even the ureteric stones, you can do alpha blockers and alkalization for stone more than 5 millimeter.
And radiolucent ones.
Yeah, radiolucent one. Radiolucent stone more than 5 millimeter, especially suspecting uric acid stone. It improves the stone clearance.
Okay. And the other thing, I mean, maybe a practical one, because the time has been reduced from 10 minutes to 7.5. So the first question was, what are the questions you will ask? Whether we can summarize, like, I will assess the patient in the view of, risk factors for stone formation, complication of these stones, like that, or else if we, that's where we're stuck in these days, history, we drag on for a couple of minutes and the time is lost. I don't know how it is going to be in the real situation.
How to tackle that area is now, if there are salient things, you need to just mention without using a lot of words. I will look for risk factors such as this, and this. So, because if you just say risk factors and we don't know what you're talking about, that sort of approach.
Okay.
Yeah, just to sort of just to sort of mention the salient things that way.
Yes.
Yeah. Okay.
Right. Shall we move on to Dr. Nishant then, who's going to be the next candidate, and Manjula sir again is going to continue his questioning on the same topic.
Yeah, this same patient, now he opt to go for ESWL for his renal stone, and he's not worried about his, ureteric stone, but he is not worried about his renal stone to treat at the same setting. So what advice you give this patient prior to this procedure?
Since he is having a ESWL, he's having a ureteric stone as well as the renal stone. So first I will assess whether the stone is suitable for ESWL or not. If it is suitable, I will advise him that clearance might be not adequate.
So what are the criteria? What are the criteria to say that this patient is suitable for ESWL?
Yeah. I wanted to assess the anatomy of the caliche system, whether the
so we are dealing with the ureteric stone. You want to get rid of ureteric stone because he is a frequent traveler.
Okay, in that case, ureteric stone, it should be the upper ureteric stone. It should be less around 1.5, less than 1.5 centimeter. We can consider. Okay, so we can consider upper ureteric ESWL in this patient. If it doesn't have any other sepsis, so aortic aneurysm, other contraindications are not there. The density of the stone also matters. If it is less than 1,200, we can go ahead with the ESWL in this patient.
Okay. So what are the type of ESW machine you know?
There are 3 types of machines are there. According to the source of ultrasonic wave production, hydraulic and electromagnetic, and piezoelectric machines are there. Nowadays, the electromagnetic machines are used, but piezoelectric machines are also there.
So what is the main difference with electromagnetic and piezoceramic ESW machines concerning the stone fragmentation and side effects?
I'm not sure, but fragmentation will be more with a electromagnetic one and availability.
Yeah. How do you, what are the contraindications for ESWL?
If the patient is having bleeding diastasis, uncontrolled hypertension, and also pregnancy and sepsis, and recent vicinity aneurysm, renal artery aneurysm or abdominal aortic aneurysms. These are contraindications.
So what is the place for antibiotic prophylaxis?
There's no proven benefit with antibiotic prophylaxis unless confirmed sepsis is there. That also not sure, sir.
Yeah, okay. Okay. So what sort of analgesic you use in this patient?
We can give no, opioid analgesics can be given, oral analgesics.
Okay. So what I mean, do we need to anesthetize patient for ESW or
no need, unless if it is a child, then in that case, otherwise no.
Okay. What sort of positioning you do for ESW? You know about the positioning method?
I'm not sure. Previously, water tank, they had electrohydraulic one. The patient has to stand on the water bath, but nowadays I'm not sure about. Might be the supine position.
Okay. So what is the frequency you set to get maximum fragmentation outcome?
Yeah, no idea. Yeah, I couldn't remember this.
Okay. What is the energy use? No idea.
They use the ultrasound scan, ultrasonic wave, which produces heat and vaporizes that, and also produces bubbles, which produce small jets that also will break the stone.
So, do you know about ramping during ESW?
No.
So, what are the method of imaging?
They can use ultrasound scan to localize the stone, or they can use fluoroscopies.
Okay. Okay. Can you let me about the you partly mentioned about the cavity, the fragmentation sequelae? Anything else you want to add?
There will be initially a high positive wave. Then that will break it causes erosion on the proximal and distal part of the stone, and in shattering of the stone in between, and then the negative wave will be given. Then with that negative wave, there will be suction, vacuum effect will be there. With that, there will be bubbling, bubbles will form and water jet will be created. That will cause further fragmentation.
Okay. This what is the place for stenting in ESW? What is the outcome after stenting?
There's no I'm not sure about the studies, but if in clinical practice, what we used to do is, if the stone size is more, then we better to predict that patient might go into obstruction, stain stress. In that case, we use stenting. Otherwise, research wise, no significant evidence for stenting, pre-op stentings for ESW.
While this patient having ESW, he is complaining of severe pain at the skin level, where this shock head.
So it
focus.
Yeah, it might be inadequate that means there should be for the coupling skin level between the machine and
How
water.
frequently? Yeah, thank you. Good. How frequently we can repeat the treatment?
There is no the studies to suggest how long we can go, but ideal with each ISWL there will be renal nephron small hematomas and fibrosis will occur. So most of the time 2 times normally we try, or otherwise maximum 3, not more than that.
What is the place? Can we do ESW for patient with pacemaker?
Time, sir.
I'm not sure, sir, but with the settings we can go ahead even.
Right. Time, sir.
Okay, so the few things the patient we have to advise that we have to tell that patient is to lie on when you advise prior to the procedure, he has to lie without moving during this procedure. And if he has any issue, then he has to, without moving, he has to tell us, right? If the pain is can't tolerate or anything, and then that is the main thing we have to tell prior to the procedure. And after the procedure, then you have to advise about he might develop hematuria, he might develop pain. If the patient develop infection or anything subject to an infection, he has to come back.
And Shantan, one more thing now, I think you need to listen to the question very carefully now. First time Dr. Manjula asked about what advices will you give. So straight away focus on the question. Otherwise, you waste time going around very vaguely. You go around. So next time, straight away get into the focused question and focused answer.
Yeah, this is actually a difficult question.
Difficult one, yes.
Yeah, that is, yeah.
And the other thing you can add about the time, because the outcome you can't get instantly. Sometimes you need to wait for the outcome. So that has to be informed to the patient. And maybe several attempts. My first attempt may be unsuccessful, partial fragmentation, and then you need to go for a second attempt. And the third thing, sometimes these patients, they made ancillary procedures and then the complications, as Dr. Manjula mentioned.
Yeah, then the electromagnetic and piezoelectric. Electromagnetic is more powerful and the more complicated, I mean, the more hematomas and the more hematuria episode. And sometimes pain also more with electromagnetic than piezoceramic. And electrohydraulic now we don't use. But the fragmentation is less in piezoceramic one. Then especially this patient, the preparations, the precautions and preparations, the patient should be infection free. You have to treat infection beforehand. If it is obstructed infectious system, you have to treat it beforehand. The contraindication, pregnancy, aortic aneurysm in the vicinity of the ESW site, extreme skeletal deformities, anatomical obstruction distal to the stone, yeah, those are, and the bleeding condition, which is a condition which is not controlled. And antibiotic not routinely give, but if high risk patient or patient with stent and infections, history of infection, you can do antibiotic prophylaxis. Analgesics mainly we give for adults, we can manage with oral analgesics, sometimes fentanyl or morphine, maximum mainly NSAIDs, but beforehand, and then morphine and fentanyl sometime, and sedation or general anesthesia needs for children sometimes. And positioning the new machines, not very little positioning that we use, but sometimes mid-ureter we have to put prone, and mostly we can manage with supine. And the frequency we use is 1 to 1.5 hertz. And pulse, the rate we use 60 to 90 to get the maximum yield of fragmentation. Because this is, we have to allow sometimes to these air bubbles to collapse for fragmentation. So we initially they use 120, now they reduce to 60 to 90. The ramping is advantage with we start with low energy setting and go up, and which cause renal vasoconstriction and which reduce the renal damage. But the actual, there's a doubt about the actual outcome of renal damage, whether it's reduced or not, is not conclusive. And method of imaging is fluoroscopy and ultrasound scan. You have to check in 2 lines to make sure that we are focusing into correct depth. And he mentioned most of things about this fragmentation. And then stenting reduce the stone clearance after ESWL. But if you suspect a stone tracé on any obstruction, then we have to put a stent to prevent the possible complication of stone tracé. And he mentioned about acoustic coupling and pain well, and retreatment. The ureteric stone you can treat even next day, but there's no consensus agreement about the interval. But generally, we wait for at least 3-4 weeks for kidneys, and the number of ESW sessions for kidneys. Generally, most of places they reduce to 3, because if it is not fragmenting, it is not fragmenting. Because more you do, more chance that you can cause a long-term renal damage and contracted kidney risk. And patient with pacemaker, you need to depend on you need to get cardiologist's opinion, electrophysiologist's opinion before you do ESWL. And shock wave number count, usually they depend on the machine, but 3,000 to 4,000 we can do, but the individual manufacturer give their own counts. And so after treatment, you can give medical expulsive therapy and analgesics as adjuvant to clear the stone. And you have to re-image in few weeks time and see whether the expected outcome achieved. And the complications are the stone tracé, residual fragments, colics, infection, hematoma, hematuria, subcapsular hematoma. And according to the EUA guideline, there's no documented evidence that this ESW causes CKD unless you do many times ESW to the kidney. That was upon early period. Okay, anything else?
Good.
Yeah, few more things. Very good questions. I have to thank Manjula sir that you have prepared very well, and even Nishant answered very well. Few things. Nishant, what are the 4 components of a ESWL machine? We have discussed everything, but I'm just summarizing it. They ask, what are the 4 components of ESWL machine? Nishant.
Ultrasound shockwave producer.
One is shockwave generator, generator or energy source. That is a one. Yeah. Next one.
And other thing is coupling between the skin and the
before the coupling.
Produce. Then,
we need a focusing device.
Focusing device.
Then they will ask, what are the focusing device you know?
Yeah,
what are the different
device depend on the type of production. If it is a physotonic, then we have to have concave piezoelectric. Then we have to have a concave shape focuser, and also if we are using
one is focusing disc, like your disc TV, focusing disc. Other one is lens, acoustic lens. Other one is parabolic mirror. Parabolic mirror, right? So these are the 3 focusing device. So one you said energy source. Second one is a focusing device. Next one you said coupling agent. Coupling agent or media for transmission is either water or gel. The 4th one already we discussed, the imaging modality. It can be image intensifier or ultrasound scan. Those are the 4 parts of the any ESWL machine. Next question they will ask, okay, in your center, what kind of ESWL machine? Because they won't see whether you are just talking theory or whether you know about this. So what is the type of ESWL machine you have used in your center? So what machine? Do you know the name of the brand?
No.
So what we have, what is the machine we have in NHSL?
It's electromagnetic machine.
What is a trade name? Donia, isn't it? I think it's
Donia.
Donia. Now, what they are bought recently for Columbus South? What is the type of machine? It's a straws. Not straws. I think again Donia. I think another sir is again Donia, isn't it, sir? They bought Donia. So then other machines available is Strauss Modulith and Siemens Lithostat. Maybe you don't need to remember the name, but they might ask you whether you know that you have seen the machine, right? So Donia machine and Strauss Modulith and Siemens Lithostat. At least just know the one name and you can just escape. So we use a Siemens machine, or we use a Donia machine, right? That's the second point I want to say. Third point, can you draw the waveform and explain me how the shock wave work? That's a common question they ask. They will give a paper and pencil, and can you draw the waveform and explain me how the shock wave work?
Normally, there will be a positive initial short positive wave.
Yeah, explain that. I don't know, my picture is this is a picture from your book. Just explain. So x-axis is what?
X-axis is the wave pressure, and the other one is the time.
Time. Y-axis.
Y-axis is the pressure, and the
then the wave, the positive wave is short time.
Yeah, it will be the short and long one.
Yeah, what is the purpose of positive wave?
Positive wave is to cause abrasion in.
It compresses the stone, makes cracks in the stone. Understand? So it's known as compressive phase. What is the action of the negative wave? Because of the negative wave, create the bubbles inside the stone, right? Then again, next time positive wave, each bubbles will rupture and they produce the micro jets through those cracks. Understand? Then stone break. Okay, so the positive, so you have to know about this. They will ask about this wave. You have to draw and explain. Very popular. That's a one shock wave. Understand? Then Manjula sir explained three important parameters. So what we use normal settings are 1 hertz. 1 hertz mean 1 shock per second. Tick, 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 so like that. So for a minute, it will be 60, right? So 1 hertz or 1.5 hertz. That's a one setting. Second setting is the number of shocks. As Manjula sir said, ideally 3,000, 2,000 to 3,000. Third thing is power. What is the range of the power? You know, the machine? 0 to 10. Like you use in IPL, we increase the power. Here also power 0 to 10. So you start with the low power and you can go up to the 10. So more, when you increase the power, more fragmentation, but it's painful to the patient, right? So three settings in the shock ESW machine. One is a hertz. Other one is the number of shocks. The third one is the power, 0 to 10. Then the next question they will ask, they will show you a CT scan. This patient underwent ESWL, complaining loin pain, and they will show you a CT scan with a perinephric hematoma. Then you have to tell there's a perinephric hematoma. Then they will ask, what are the risk factors for this? Do you know any risk factor to develop perinephric hematoma?
Infection, undetected infection.
So simple. One is on patient on antiplatelets, like clopidogrel aspirin. Second one, patient on anticoagulations. Third and important thing is hypertensive patient. More increase the high the pressure, more perinephric hematoma. Then they will ask, okay, we manage conservatively, but patient now coming with persistent, medically resistant hypertension. What is the reason? Can you explain the reason?
Renal. Yeah, it could be a renal hypertension
hematoma
causing reduced renal perfusion.
So what is the name for this condition?
Renal artery stenosis or
Page kidney, page kidney, right? So that they might ask. So these are the additional points I think I want to say. And just remember SSD, skin stone distance less than 9 is favored. So obese people, it's not favored. Yeah, I think that's all.
Thank you.
Yeah.
Okay.
We can move to the next one, Thilina.
Yes. So Dr. Nalin will be the next candidate, and again, Manjula sir will continue his question.
So, Nalin?
Good evening, sir.
Unfortunately, after discussion with Nishantan and Hillary, the patient was decided not to go for ESWL, but he want to get this done in one go with ureteroscopy, both stone together, right? So, what specific event you discussed during consenting this patient?
So this patient has 2 stones, one in the ureter, one in the kidney. So the specific event would be that if we fail to proceed with the ureteric stone, we might not get the renal stone. So probably this patient might need flexible ureteroscopy rather than a semi-rigid ureteroscopy.
Okay, right. Okay, can you briefly explain about the procedure? Basic important steps. Patient anesthetized in lithotomy position, legs there. So how do you explain the procedure?
So this procedure has to be done under general anesthesia, and once the patient is positioned, initially I will do a rigid cystoscopy to assess the urethra and the bladder, and then once I do a complete assessment of the bladder, I will empty the bladder and insert either a small gauge catheter or a feeding tube to assist me during the ureteroscopy. So I will initially start with the semi-rigid ureteroscopy. For that, with the cystoscopic guidance or even with the ureteroscopic guidance, I will initially put a guide wire, and then with the second guide wire mounted onto the ureteroscope, I will proceed along the ureter up to the point that I can see the stone. And
when you try to go negotiate the ureter, it's very difficult ureter. So what are the maneuvers you take to insert the ureteroscope?
So one thing is I will advance it between 2 guide wires. And the other thing is I will start with the smallest possible gauge, that is either 6.5 or 7 French ureteroscope. Those are the initial steps that I would consider if it is a difficult one.
Okay, so now somehow you were able to negotiate into the ureter. Now explain rest.
Sorry, sir, I couldn't get the question.
You were able to negotiate into the ureter now. Now, can you explain rest? How do you go ahead?
So then I will proceed until I see the stone in the ureter, and then with one guide wire passing beyond the, keeping one guide wire passing beyond the stone, I would consider using laser lithotripsy to break down the stone. So starting with the most prominent part that I can see, I will start breaking down the stone and taking out the pieces. So if I can break down the pieces less than 1/4 of the field that I can see, I will let them pass spontaneously. Otherwise, I will use Uromet basket.
Yeah. What are the other energy source you can use for your?
Yeah, the other energy sources that can be used is the pneumatic lithotripsy, which is commonly used in Sri Lanka. But the problem with that is it can damage the ureteric mucosa, so that it has a higher chance of developing ureteric strictures later on.
So now,
other sources of energy would be ultrasonic energy combined with suction and laser as well.
Yeah, okay. Now the how do you prevent, because this is upper ureteric stone and you don't have flexible URS assuming this stage. How do you prevent migration of this stone during the procedure?
So yeah, one thing is I would keep guide wire throughout the procedure, passing beyond the stone. That is one technique. Other thing is, if I can get hold the stone with a domia basket, then I can target the stone holding with the domia basket. Otherwise, if I have a balloon device which I can pass beyond the stone and keep the stone without migrating, that is also possible. That depends on the availability of the balloon devices.
So unfortunately, after breaking half of the stone, you thought that I will do the lithotripsy with the domia basket. So your basket stuck and you can't pull it out. So what do you do now?
So then with the basket, removing the external part of the basket, I will come out and keep the domia basket inside the ureter, and then again go along the domia basket until I see the stone and the domia basket entrapment. And then with the domia keeping a slight traction on, I will try to break the stone completely so that I can get the domia basket released from the stone. And then I will gently remove the domia basket after breaking down the stone into small pieces.
Yeah, if you pull the stone, what will happen without breaking?
That can avulse the ureter. That can avulse the ureter. So I would not apply undue traction to pull out the domia basket.
So what are the type of basket you know? Main.
There is a zero tip basket that will avoid undue damage to the ureteric mucosa, and the other one is the conventional basket. And there are certain baskets which has an umbrella type of basket which can be passed beyond the stone and keep the stone in position.
So what is the basket we generally use for semi-rigid? The size of the basket we use for semi-rigid ureteroscope?
I'm not quite sure. I think it's French, 4 French or less. It's 3 French or 4 French.
Ureteroscope. Flexible ureteroscope. What is the size we use?
It's 3 French or below.
Yeah. So now you try to retrieve the stone, but it's gone to the kidney. Now both the stones are in the kidney. So what do you do now?
Then since I'm going with the semi-rigid ureteroscope, I will go up to the renal pelvis and see whether I can see or whether I can approach the stone. If I cannot approach the stone, then I will gently try with another domia basket to catch the stone if it is partially seen. If not, then I will have to go for a flexible ureteroscopy. If it is not available at that point, I will abandon the procedure.
Time's up. Okay. Okay. So starting, so the same thing. Yeah, this is same thing. Yeah, doing everything. No. So consenting, especially we have to tell about the failures. So we might ended up with stents. So when you put the guide wire, if pus comes, still we don't do the procedure. And there's a risk of ureteric and bladder injury. The patient need flexible ureteroscopy if we want to get rid of both stones. And those things you have to explain the patient. And especially when regarding procedure, you have to tell about you are using fluoroscopy and safety wire, prophylactic antibiotic, and that you have to mention. And if the VOJ narrow, you can, with the same wire, you can stretch the ureter and see. If not, you can try with the two between two guide wires. And I don't know that now the people are doing VOJ dilatation with the ureteric dilators. But, otherwise, you can put a stent and do it as a second stage. Gobi, you can add later, right?
Yeah.
And then
Yeah.
the migration you can prevent with minimal flow, and especially when you do ureteroscopy, you try to use minimal pressure, because that reduces the risk of infection and loin pain if you do under spinal anesthesia, and risk of migration of the stone. Minimal pressure of saline during the procedure. And then other thing is, he said about the guide wire itself prevent progression of the stone. And there's a thing called stone cone, or sometimes there's a balloon, and you can catch the domia and break the stone. And then basket, if it's stuck, the two method, one is to, yes, you dismantle. Sometimes without dismantle also, you can put the laser fiber through the same channel. If you can't, you can
if you are using a dual channel scope, that will be easy.
Yeah, if you can't, then you can dismantle and go back. And sometimes you may have to break the basket netilon wire as well to dismantle it. It's stuck, right? And if it is difficult, then you have to break it halfway and remove the guide basket after breaking the wire, and put a stent and come and do it in the second stage. And any difficulty, don't get, always put a stent and come back, right? And then migration, yes, zero tip and tip baskets. Tip basket, the problem is the tip can damage the ureter. And the special basket like this, I think the fish mouth or umbrella basket, frog mouth, various names are there, where you can catch the stone and you can release the stone when you expand it. And especially used for the catching the lower pole stone in flexible ureteroscopy. I think the size of the flexible ureteroscopy basket we use 1.5 to 2.2. Is that correct, Gobi?
Yeah.
French?
Yeah.
Yes.
And yeah, most of the rigid ureteroscope use 3 French basket. And yes, and then you mean I might need to explain the flexible ureteroscopy, the steps if relevant, yeah, how to do, etc.
Yeah,
and
few more things, Nalin.
Yeah. Nalin. Sorry, Gobi. Yeah, go ahead.
Dr. Rangan, you asked, then I can ask the rest of the questions.
Right. No, I just wanted to ask the mechanism of fragmentation using a laser, especially a homeomag. Yeah, Nalin.
Sir, I couldn't get the question, sir.
What are the mechanisms of fragmentation? If you use homeomag laser, what mechanisms?
Yeah,
how do you fragment?
Yeah, there are mechanically there are 2 types of fragmentation. One is by evaporation, where the laser beam causes elevation of the temperature more than 100 degrees Celsius. So by that there is fragmentation of the stone. The second one is the laser
photothermal. That is what you call photothermal.
Yeah, photothermal. And then the second one is photomechanical, where the irrigation fluid or the molecules get the mechanical energy transmitted by the laser fiber, and then it hits on the stone and breaks down into small pieces.
Yeah. What are the different techniques that you use to apply the laser on the stone?
One thing is you can use the painting technique, where you go close to the stone and break the stone like as you are painting a picture. And the other one is popcorning, where you keep the laser fiber away from the stone fragment, so that, and then without targeting a specific place, you release
Any
the
instance where I use the popcorning? Any instances where I use the popcorn?
So when there are multiple fragments,
particularly
which we need to break down.
Yeah. Yes. What are the other 2?
The 2, of course, I can't remember.
One is chipping technique. Chipping for the hard stones, you apply from periphery, you chip into small pieces. The other one is fragmentation technique, where you have a very hard stone, you straight away go to the center. You go into the center and try to integrate into large pieces. So you have 4 techniques: dancing or painting, chipping, fragmenting, and popcorn technique. And the other thing I wanted to ask, one second. All right. So what are the things that you can modify when you are setting the laser? What components can in the machine?
Yeah, that depends on the different types of machine. Generally, what we change is the hertz, the frequency, and the energy source.
Okay, so you have that is what we call the energy, pulse energy, pulse frequency, and also pulse width. 3 settings that you can change. So what is the difference between the dusting and fragmentation? How do you set up? What are the settings for these 2?
So generally for dusting, it's high frequency, low energy.
Yeah.
And for fragmentation, it's vice versa. That is low frequency, high energy.
Which one will have the more chance of retropulsion?
The fragmentation will have more chance of retropulsion.
Well, it's with the high frequency, Nalin.
Yeah.
And anything else to ask? Basically, yeah, I think yeah, we have covered. Gobi, up to you. Anything else?
So Moses technique, sorry Ranga, I'm Suraka. Moses technique, can we prevent retropulsion?
Yes, it's an advantage where we can adjust the wavelength and the pulse width, and then to reduce chance of retropulsion. Moses, it's a new technique in one of the new generation machines.
Yeah, Nalin, in the rigid cystoscope, what kind of system we have? Is it like we have fiber optic cables and things? So what system is there in rigid scopes?
We have a rod lens system in the rigid cystoscope.
Okay, so who invented this rod lens?
Sorry, I can't remember the name.
Hopkins.
You should know. You
Hopkins.
can't say that I don't know.
Right. Okay. Now, what are the different the objective lens? What are the degrees of different rigid cystoscope you have?
Yeah, that depends on the manufacturer. Commonly, whether it's Carstow's or
degree of angle. What is the commonly we used cystoscope?
We commonly use 30-degree angle, but we have 0-degree, 12-degree, and 70-degree angles.
Yeah, tell me a situation where you use a 0-degree.
0-degree when we use optical ureterotomy, and in certain instances where we want to take biopsies in particular cases.
If we cut the cross section of flexible cystoscope, what are the holes we will see, or what are the things we will see?
We will see the rod lens as the larger.
I'm asking about flexible cystoscope. Flexible.
Sorry. So if it is a chip on the tip one, we will see only transmitting wires.
Usually? Which one you
use? We have fiber optic ones.
Okay, just tell me about fiber.
So we have 3 ports. One is the fiber optics, which carry the optical or the eyepiece from the eyepiece down, and then the fiber optics, which carries the light source, and then we have the irrigation lines. There are 2.
Now you are going. Your light cable is damaged, and you are requesting a light cable to the hospital. Whether light cable is expensive or your camera cable is expensive, and why?
Light cable contains more fiber optics, so I think it's more expensive, but I'm not quite sure. I think the camera wire only contains the the conventional
Camera
wires. So,
cable is very expensive, Nalin, when compared to the light cable. What's the reason? Both have fiber optics. Okay, what's the difference then? Why the light cables is not expensive, but the camera cable is very expensive?
I think because it's more compacted in the camera, so you have more fiber optic fibers. I don't.
Yeah, the fiber optic cables are arranged coherent way that, you know, even a minor derangement in the one fiber optic cable, the image quality will go away. But a light cable, that is not the issue. We need just a light, so they can come in, you know, non-coherent way. So that's why light cables are cheap, camera cables are expensive. Now you said in a digital scope, what's the difference? You said something CCD.
Yeah, chip on the tip.
What does CCD stand for? It's coupled charged device. Okay, CCD. Where is the CCD is located in the scope?
It's on the tip of the scope.
Tip. Okay. So we don't have a, so when you are doing a flexible sister scope with the fiber optic cable, sometimes you will see black dots. So what's the reason for that?
That's breakdown of a single fiber optic.
Will you get that kind of black dots in a digital scope?
No, you don't get.
Okay. In digital scope, do we have a separate light cable and separate camera cable, or is combined together?
I have not seen one, but I think it should be combined because it transmit the images are taken from the tip and then transmitted to the external device.
Cable. They have only one cable, light cable and digital the camera cable, both are in one cable. Right. Our semi-rigid scope, semi-rigid URS, what kind of system it have? Is it a rod lens, or is it a fiber optic, or is it a digital?
It's a rod lens. Semi-rigid rod.
Is it again fiber optic? So our flexible and semi-rigid both have a fiber optic. Okay. Now you know about all those things. Now your hospital is asking you to purchase one flexible ureterorenal scope. What are the important parameters you will see in a company's request, or you get an order? So what are the things you will see in the flexible URS? What are the parameters you will see?
One thing is the size, that is which size it is, French size, and then whether it's fiber optic.
Size of the tip of the scope. So more smaller the scope, it's good for you. Yeah, but more smaller the scope, the working channel will be smaller. Yeah, okay, right. And what else? So you will see the tip diameter. What else you will see?
And then the number of working channels, whether it's single or
yeah, usually flexible URS will have only one working channel, isn't it? Yeah, that will be around 3 French. Yeah.
And then number of cycles that it can generally be used. Like
what about degree of cycle? Degree of deflection? That is more important, isn't it? Whether it's 270 or more than that or less than that. Okay, so you have to see length of the scope and degree of deflection and the proximal end diameter and size of the working channel, of course, you have to see, right? What are the new advances we see in the flexible ureteroscope? One thing is it's becoming smaller and smaller, smaller outer diameter. What else? More and more deflection, isn't it? Initially it was 180, now we get 270 and things. What else? We get two-way deflection. They deflect this way and deflect that way. Two-way deflection. Okay, what else? There are active deflection and passive deflection. Okay, and what else? In cross-section, they become oval shape. So what is the advantage of oval shape? Irrigation fluid can easily come out, right? So, and tip is a ceramic tip, so laser won't damage a lot, right? So these are the new advances of, I think time is going, so I don't want to go on like that. So we move to the next one. Lina.
Disposable cystoscope, flexible cystoscope.
Disposable.
Yeah.
And just know about the mechanisms. What are the mechanisms of damage to the flexible scope and how do you prevent? You must be able to say 1, 2, 3, 4, 5, how to prevent damage to your scope, how to safeguard your scope during laser. Right, we'll move on.
Yeah, so next is Dr. Munipriya, and again, Manjula sir, over to you.
Yeah, okay. So next one is Munipriya.
Yes, sir. Good
Not the
evening, sir.
same patient now, different patient come to the clinic.
Okay.
The 56-year-old patient who had a cardiac arrhythmia on permanent pacemaker presented with right-sided 4 centimeter lower wall renal tube, right, which is amenable for partial nephrectomy. So after discussion within the MDT and the patient, he decided to go for partial laparoscopic partial nephrectomy. So can you let me know the energy devices you use in laparoscopy and what energy devices you select for this patient? First, you have to tell me about the energy devices you use and which one you select for this.
Energy devices. The first is the light. We want to get the light. Then the energy devices as used in the dissection. Usually in laparoscopy we use the diathermy. So in this particular patient is having a permanent pacemaker. So when we use the monopolar diathermy, we have to cautious about the using the monopolar. So because of that, we have to use the bipolar diathermy. And the other energy devices which we can use is harmonic scalpel and then ultrasonic scalpel. And Thunderbeat. Those, yes.
Yeah, okay. So can you let me about the monopolar device? How the monopolar device cutting mechanism going on and how the coagulation happens?
Monopolar device, the cutting mechanisms is we use the continuous high frequency energy. So tissue, the tip of the instrument will get heated, and the tissue evaporation will cause the cutting. And in coagulation, we have to use the intermittent blend mode, that is intermittent frequency, and then it is tissue, the heating and coagulation will take place.
Yeah, okay. So what is blended cutting?
A blended cutting is the mix of cutting and the coagulation.
So what is fulguration?
Sorry, sir.
Okay. So telling me about bipolar energy device used in laparoscopy.
In laparoscopy, we can use bipolar scissors, and the Marylands we can use as a bipolar device, and that is the diathermy. And also is a harmonic. Also, I think it's a bipolar mechanism is there in harmonic scalpel.
It's not harmonic, it's a ligacho.
Oh.
Bipolar. So what is the I mean argon beam coagulation? The argon beam coagulation, what is the difference there? It is a monopolar system, but we use argon beam.
It's the we have it is used the argon as the heat source, and I can't
Argon
just
means because when there's a fluid contains the monopolar, the current disperse everywhere, so it is not focusing. So there's a argon gas around the argon beam electrode, so it keep away the water away from the coagulation area, and especially used for liver
and
coagulation. Yeah. Okay. So what are you said about electrosurgical device? What is the other surgical other energy device we use in laparoscopy? The harmonic?
Yeah, okay. Harmonic and ultrasonic devices, and then thunderbeat and sound reach.
Yeah. So what is the difference between ligashoe or the bipolar device and harmonic device, considering vessel sealing and collateral damage?
According to the manufacturer explanation, the ligashoe has more benefit to sealing the blood vessels up to 7 millimeter veins we can coagulate. Compared to the harmonic, it's much benefit, but harmonic is less than up to 3 millimeter. I think we can get the sealing effects.
The collateral damage?
In collateral damage, the harmonic has more collateral damage than the ligashoe.
So if you are doing a radical prostate, if you want to dissect around the neurovascular bundle, which one you use? Ligashoe or harmonic?
So in that case, it should be less the collateral damage. So because of that, I will use the ligashoe.
Yeah. Okay. Can you tell me about the complication of energy source during laparoscopy? I mean, whatever the energy device you use, what are the complications they can get?
The complication can be the general complication as well as the localized complication. In general complication, because of the energy transmission by using the monopolar, so we can get the damage in the peripheral areas rather than the dissecting area. So skin burning, and if the energy transmitted through the especially the pacemaker like that, the device, the adjustment will change and can cause the cardiac effects. And then local through the port site,
What is the name called? Capacity to coupling.
Coupling, yes, coupling.
Sorry, it is a difficult one, but because then you at least you read and go. No? So they can, if by chance if they ask, you know something. Because most of
thank you very much.
questions are difficult one. They may not ask you that extent sometime in the exam, but better to know those things in case if they ask, you can get away. So mainly if somebody is a permanent pacemaker, then you have to beforehand you have to discuss with the electrophysiologist and either put into the correct mode before you start. So energy device, yes. Electrosurgery, monopolar cutting, yes. It is mainly the high voltage, and because it's cause evaporation and tissue break, so cell break and making cutting event. The coagulation mainly it is heat and cooling. It's intermittent current flow, and that cause more coagulative effect than cutting effect. Blended cutting it's a mixture of coagulation and cutting. So other thing is fulguration, where we keep the the special mode where keep the probe a few millimeters away from the surface, where the spark of current goes and it's like a spraying, like argon beam. Then considering this bipolar Liga shoe, it has a more sealing effect as well as it has more collateral damage. So if you are doing a neurovascular dissection, better to use not the Liga shoe, but maybe harmonic. And the sealing effect of harmonic is less, it's about 5 millimeter vessels. And other thing is the harmonic, the cause less smoke and compared to Liga shoe. And then the direct injury, capacity to injury, insulation failure, diaphragm pad burn, and sometimes when you activate the monopolar current, because especially, I mean, this may not be related to this, but if you do in a way the small vascular pedicle there, if current goes through that small vascular pedicle, it can damage to that pedicle. So that is other important thing. So anything else, Gobi, you want to add? Not there.
Dr. Manjula, you can ask about the hemostasis methods also at the same time.
Yeah, sorry, I forgot to tell. Can you tell about the hemostasis mechanism in laparoscopy? Better do you achieve hemostasis in laparoscopy, especially this partial nephrectomy?
Yeah, one thing is using the energy devices, we can achieve the coagulation effect of the vessels. Other thing is the suturing and the clipping technique. So in suturing, we can use the barbed sutures to prevent the damage, and we can achieve the
what is the advantage of barb?
It is once we apply force, it keep stable rather than the losing the force. So it is one side direction.
You can only it is only one side direction, so it don't slip.
Yeah,
I can put the tension over the suture line.
suture line. Yeah.
What else?
Then we can use the glue, the tissue glues, and we can use the cellulose, the coagulation material like Surgicells, and then
And there's patient's own plasma they can
yes,
extract.
plus yeah.
And what else? Clips.
Yes, clips and the hemolocks. But in partial, we don't use the yeah.
And the other thing is this
step
and Surgicel. Yeah.
And staplers also we can use.
Okay, Gobi, over to you.
Yeah, similar question they will ask is you are doing a TURP in a pacemaker patient. You don't have a bipolar machine. What are the precautions you will take? All the answers are given in the FRCS Viva book, so I'm not going to ask those things. Please read about it. And they might ask, what are the effect in the heart when you use a monopolar? When you use a pacemaker, 3 things. One is arrhythmia, cardiac arrhythmia. Second thing is the cardiac arrest. Third thing is the cardiac burn. So we have to keep a defibrillator ready in the theater. So those are the things you have to tell. And regarding the advanced devices, all these ligashore and those things are known as advanced energy devices. So if you are using the advanced bipolar, example is the ligashore. That's also known as advanced bipolar is known as electrothermal bipolar vessel sealing device, EBVS. So bipolar technique, ligashore. Then the ultrasound wave is a harmonic that we discussed. When we combine the bipolar plus the ultrasound wave, is a thunder. So how this name came, thunder beat? Thunder plus beat. Beat sound, thunder energy. So that's a thunder beat. Thunder energy, bipolar energy kind of thing. And beat is sound. So ultrasound plus bipolar is a thunder beat. I think rest of the things were discussed. So yeah.
Okay, anything else?
No, that's it. Basically, I think we covered.
Yeah, shall we move to the next one?
Yeah.
Yes, please. Yeah.
Dr. Taha is going to be the next candidate.
Yeah. Hello, Taha.
Yes, sir.
This is actually a case when you were in Kandy. So 34-year male admitted following RTA to left loin RTA with left loin pain and bruising. And there's a subcutaneous hematoma in the left loin region. Right? So patient in ETU, how will you assess the patient as initial management? I need only the brief management plan, especially concerning this urological pathology.
It's an trauma setup. I will attend to the patient early as possible without any delay. I will approach the patient in a manner, advanced trauma life support manner, where I will go into ABC. I will start with 100% oxygen saturation, two large bore cannula. I will make sure there is no other major organ injuries like airway breathing. After that, I'll make sure that patient is under pain control, and I will assess this patient at a multidisciplinary setting also. Like I might need help from general surgeon, emergency physician, anesthetist, as well as orthopedic colleague. After stabilizing the patient with analgesics, I will take a focus history as well as a relevant examination. In focus history, I'll ask the duration as well as the mechanism of injury and any other sinister urological findings such as blood in the meatus, inability to void, and the sequence after the event. On examination, I will start from general examination such as pulse rate, BP, respiratory rate, and I'll move on to the abdomen where I will see whether there is any tender point. The history says there's a hematoma on the left loin, and I will look at there bruising, any palpable fractures, any sort of on the reduced respiration on the same side, and I will go on to the examine the pelvis and the perineum to complete my examination.
Okay, so after that you decided to go for renal imaging. So what are the criteria for renal CT imaging? On what
So in
ground?
adult patient, the critical or the red flag signs are visible hematuria or penetrating injury or mechanism of injury like rapid deceleration, acceleration, injury, or fall from a significant height. If one of these features are present, I will go for CT urogram where I can state the disease as well as I can look for other organ injuries.
Okay, what are the major renal injuries that doesn't show hematuria?
So grade 5 injury where the pedicular injury or pelvic ureteric junction disruption, there may not be evidence of hematuria. That's a grade 5 injury without hematuria.
Okay, so can you explain the grading system of renal trauma?
That's the AST grading system. That's the American Association of Surgery into Trauma. Grade 1 is contusion. Grade 1 is contusion. Grade 2 is laceration less than 1 centimeter or subcapsular hematoma, which is not extended into perinephric area. Grade 3 is laceration more than 1 centimeter, which is not extended to the corrective system. Grade 4 is there is a segmental arterial, segmental vascular disruption over the correcting system involvement. Grade 5 is complete shattered kidney or pelvic junction disruption.
Okay. So what are the phases important in CT scan for this patient?
So CT scan, the initial phase would be the arterial phase where I can see whether there is any arterial or vascular injury. Then the nephrogenic phase would be in 60 seconds or 60 to 90 seconds or 1 minute time, where I can state the disease, and as well as if I can combine, if I have a doubt of excretory system injury, I can combine excretory phase also like in 10 minutes. In grade 4 or 5, where I have the hematuria, I will combine with excretory phase also to exclude ureteric injury or pelvic LSA system or draining system injury.
So what are the indications for non-operative management and angioembolization?
If the patient is stable and if there is grade 3 or 4 injury, I can offer angioembolization. Actually, grade 4 injury, sorry.
Okay. Can you explain me indication for exploration?
Exploration, if the patient is having life-threatening bleeding, which is obviously or which we have suspect that is arising from the kidney, or else if we have grade 5 injury, suspecting grade 5 injury, most of the time, most penetrating injury where we have doubt of grade 4, grade 5 injury. And if there is any other organ injury which has been opened, for such as like splenic injury, then that is also an indication for open approach.
Okay. So what are the after this I mean grade 4 renal injury, what are the problems he can develop in latter part of his life?
So grade 4 injuries, there's parenchymal injury. So there can be a renal loss scarring, and then patient may develop hypertension because of the scarring. So that renal insufficiency and scarring and hypertension.
Okay, so those are the questions actually I have prepared. Anything else, Ranga?
So we have basic covered, isn't it?
So he did before the time, no?
Yes.
Taha, suppose if a patient have a bilateral 1 centimeter laceration, bilateral renal 1 centimeter laceration, what is the grade?
So if it is bilateral, the grade goes up, like, 1 stage up. So that is grade 3.
Yeah, good. Is there any different in trauma management, renal trauma management, pediatric and adults?
So pediatric, we have low threshold for invasive or CT imaging, because if it is non-visible hematuria also, we have to do CT. And the other thing is hypotension is a late sign in pediatrics. So we have to have a low threshold for investigation as well as management for pediatrics.
Any relation? Yeah.
The criteria for renal imaging are the visible hematuria and non-visible hematuria and 1 episode of hypotension.
Yes.
Then history of rapid deceleration injury, significant and or significance associated injury, penetrating trauma you told. Clinical signs suggestive of renal trauma like flank pain, abrasion, fracture ribs, abdominal distension or mass or tenderness, then you have to do a CT.
And you ask about that, what are the indications for angioembolizations? I couldn't answer properly.
I mean, persistent hematuria, and where if you, when you do an angiogram, if you can find a bleeder, then you have to do a angioembolization. Then other, I mean, this is non-operative mean it is not a removal of kidney. If there's a urinoma which is progressively expanding, then you have to drain it. Just purely extravasation of urine alone is not an indication for stenting. Is that Taha, the Gobi? Because in PCNL we do extravasation, you know?
Yeah.
So it is expanding perinephric or with associated infection.
Yes.
Because the PCNL make a lot of changes in renal trauma management, no? So, oh,
Yeah, I think we might, Trina, we can move to the next one, isn't it?
okay.
Can we move on to another case scenario? We have about 12 minutes.
Yes, yeah.
Yeah. All right. Okay. So then I think Dr. Suranga, are you okay to take the questions?
Suranga?
Okay, okay.
Yeah. 34-year-old male came to A&E with history of persistent erection over 5 hours. So what is the most likely diagnosis?
So it is a most likely diagnosis of priapism, but I want to get a history regarding whether it is sexually stimulated or not, and if it is not, actually it is priapisms.
So how do you assess this patient?
So I will take it is actually a emergency, urological emergency. I will quickly assess with the short history and examination. The history include whether the duration, onset and the duration, and any previous history of similar episodes, and whether it is a painful or not. And then I will go for an examination regarding the general condition and the genital examination, whether it is the rigidity involved in the glands as well as the corpora, and any history, any scar or any features subject to any trauma to the penis. And then after that, I go for the next step.
So what are the possible underlying causes for priapism?
The underlying, it actually depends on whether it is a ischemic type or non-ischemic type or stuttering type. So ischemic type, there are hematological malignancies, leukemia, and sickle cell disease, and the recreational drug like marijuana or any PDE5 inhibitors, and these are the for risk factors for the ischemic type. And the non-ischemic type is a arteriovenous fistula, probably due to the trauma. And
so what are the how to differentiate from arterial priapism from the venous priapism?
So actually, the history will give the first impression by the history, and the history give the first diagnosis, and then the second is it's a painful. Ischemic types are painful, and the non-ischemic types are not painful as such. And then and the aspiration, I can do a blood gas of aspirated blood from the penis, and if it is close to the venous type, actually it is ischemic, and if the blood gas is similar to the arterial type, it is an non-ischemic.
Blood gas came as venous blood finding.
So it is then it is a ischemic type of priapism. So by the first management is the aspiration of the corpora by using a large bore cannula, large bore butterfly cannula.
So what size of cannula you use?
Number 18 gauge butterfly cannula.
So where do you going to aspirate?
I will aspirate from the 11 and 2 o'clock position, and I will aspirate at least 200, 150 to 200 ml of blood from both corpora, and then if it is not settled with the aspiration, then I can abandon the procedure. But if it is not settled, then I have to move for the second stage.
So what do you do if it is not settled after aspiration?
If it is not settled, I can flush with the normal saline and wash the red blood cells within the cavernosus. And if it is not settled, then I have to move for a medical treatment. In that case, I have used the alpha agonist like phenylephrine, but we have to more care about the cardiac toxicity and.
Can you explain me how to give the phenylephrine?
So phenylephrine, so the dose is you can give 200 micrograms, 300 micrograms per minute. Every 3 minutes we can repeat it, and the formation of
maximum dose.
Maximum dose we can go for 1 milligram. And
so, what are the other drugs we can use if you don't have phenylephrine?
So alpha alpha adrenergic actually. Ephedrine, we can go for ephedrine. For a that's for a.
So you have,
so
you have
intracavernosus.
Yeah. You have done aspiration, and then second time also patient developed and it's not settled. So now it's persisting, he's in pain. What you are going to do now? Aspiration, aspiration and medical management fail.
So then I have to think about the shunting procedures. First, I will proceed with the distal shunting, and
method of distal shunting.
So the Winter's procedure, we can put a true cut needle from the glans penis to the corpora, and actually there are to make a shunt between the glands as well with the cavernosa. At the same time, normally we can get the tissue for for histology as well, but if it is helpful in the late presentation, and then the laboratoric and the T shunt, and we can pour a T shunt, and we will insert a number 11 blade in a horizontal in the vertical manner, and then take it with the horizontal manner. So that's how we create the distal shunt.
Okay. So what are the proximal shunt, you know?
And the proximal shunt, the Safino corporal shunting, but I can't remember the name actually.
Don't worry about that. Please.
Sorry?
Safino
corporal.
Yeah. What is the other proximal shunt?
And
spongy urethra.
Yes, spongy urethra. Yes.
Okay, so patient presented with delayed, this was a delayed presentation after 72 hours.
Yeah.
So what do you do now?
Actually, if it is a delayed presentation, so we have to think about because delayed presentation will end up with the erectile dysfunction. Actually, so the best way is to, if there is any facilities, I will go for MRI scan. MRI scan will show the fibrosis, and if it is if there is a tissue biopsy, we can confirm the fibrosis, and if it is real fibrosis, we can consent for the penile prosthesis.
Okay, so what is stuttering priapism, and how you are going to manage?
Stuttering priapism is the priapisms. It is an intermittent priapisms, especially you can see in the children, and the management is similar to the ischemic priapisms, but we have to exclude the hematological malignancies and the sickle cell disease. So if there is any underlying pathology, we have to treat that and then go for a definitive management.
Any pharmaceutical agent we can use for manage stuttering priapism?
Sorry, I'm not aware.
Okay, so let's start from the beginning. Yes, good priapism, you should be able to differentiate from arterial and venous. And in history, you have to mention about his baseline erectile function, especially regarding medical legal reason, right? And yes. Yeah, that is very important. Then you told most of things, and then after, especially when you do aspiration, the one thing is don't puncture the corpora perpendicularly, because that can exacerbate and blood can collect under the skin. It should be, needle has to put in angle. And some people do, through the gland penis, they put the butterfly into the corpora and aspirate. Yeah, to prevent extravasation and edema of this penis. And patient need local anesthetic penile block. Yeah, because that's painful. And so sometimes if this settle after aspiration and what medical management, then sometimes we give diazepam or something to sleep him, because sexual stimulation can recurrence can prevent. And you told about dorsal cavernosal T-shunt and copper snake, where you dilate with the Haycast dilator, not doing much. And winter procedure, then the words are very difficult to remember. These surgeries. And I think this saphenous shunt. What do you think about Gobi? Because all this shunting has its inherent erectile dysfunction. But I think saphenous shunt is the only shunt we can reverse. We can plan.
Yes. So nowadays they are not preferring the proximal shunt. So if distal shunt is failed, then we have to go for a prosthesis or something.
No, I think saphenous shunt, if we do shunting, then we can ligate it later if patient won't get erectile dysfunction. Is that so? I don't know. This I'm thinking. Because it's saphenous vein, we can go and ligate it if necessary. Future? I don't know. Yes, I am thinking. I can't find anything anywhere. And this other thing is using this stuttering priapism, you have to look for the cause. Some people use oral alpha adrenergic drugs like etilephrine, and then this anti-androgens, GnRH analogs. Anti-androgen is better than GnRH analog because the libido is preserved, and finasteride use but not approved. Those are the drugs we can use in stuttering priapism.
So if there is no phenylephrine, so what is the drugs actually? Ephedrine?
Actually, I use ephedrine here.
Ephedrine.
Yeah, I don't know, because it's none of the books says ephedrine, no?
Yes.
No, it's not.
But adrenaline you can use.
Adrenaline.
But ephedrine is not in the books.
Yeah, other one is a metaraminol, isn't it?
Yeah, metaraminol.
You can use metaraminol.
Yeah. As we discussed this topic about a few months back in the Uromet, I think most of the guys should know, and they might ask what are the common causes of priapism? Maybe the erectogenic drugs, injection in the penis, cocaine kind of illicit drugs, hematologic malignancies always mentioned as blood picture, and pelvic malignancy and sickle cell disease. They might ask about prosthesis timing. If you are going to put the prosthesis, whether it's an early prosthesis or late prosthesis, they might ask what is a positive and negative. Early prosthesis is good, easy to put, but more risk of infection. Late prosthesis, patient is psychologically adapted, but difficult because of fibrosis. So there is a risk of urethral damage and things. So they might ask those things.
And other thing, sildenafil and trazodone has very, very low risk of getting priapism. No, it's not a very common thing. Even though I think it's a rare event.
Yeah. Dr. Nishant Lianapathan, you want to give any other input? So we have discussed 5 very good cases and a lot of inputs. Anything else you want to tell, Dr. Nishant?
I think, Gobi, it's a very good discussion. I mean, possible scenarios in renal cancer, renal trauma is one other scenario which comes to, which is given is actually the situation where you are asked to attend a laparotomy when the general surgeons are doing a laparotomy and you find a large perinephric or retroperitoneal hematoma, and they suspect there is a
renal, it is arising from the kidney. And then what are you going to do? I think there are specific indications that you're going to explore that or not. And then the technique of exploration, we need to be little aware about the where are we going to open that, trying to get the vascular control going above the inferior mesenteric artery and dissect along the aorta and then get the vascular control, and then go for the colonic mobilization and explore the renal hematoma. But then again, the indications are important. You just see a renal or perinephric or retroperitoneal hematoma. I think we have mentioned that there is a clear place for, in the setting where there's no imaging, if the patient is taken to the theater because of the instability, because if there's no imaging, at that point we'll have to talk about the place of the intraoperative on-table single shot IVU. And if the IVU shows absolutely nothing, both kidneys are draining, and I think there's no extravasation, I think we can just abandon any exploration and come out. And if the hematoma is expanding, if there's a pulsatile flow, or if there is a continuous blood leaking from the hematoma, as well as continuous urine leak with concomitant bowel injury, all these things cause sepsis. So there is a place for, again, exploration in those indications. And of course, you have to look at the other side also. And the other thing is the grade 5 renal laceration who comes with a sort of intimal tear or a sort of renal arterial dissection with the decelerating trauma. What is the place for exploration? In fact, we had 1 or 2 patients like that who came with renal lighting up. But all these things, if it goes, if the 4-hour window, I think the 4-hour is the usual time that they say, if the 4-hour window is gone, I think there's no significant benefit from exploration. So yeah, I think they will have to be followed up, because as earlier, as Dr. Manjula said, that there is a chance of late onset hypertension, so they need to be on regular follow-up. Yeah, it's a good discussion. Thank you very much, both of you, Dr. Manjula and Gobi.
Yeah, and Dr. Ranga, you want to give any more input? Yeah, actually, I have to thank that Dr. Manjula sir and Dr. Ranga that they have kindly agreed, because he was alone, Dr. Manjula sir, and he prepared all the scenarios. And I have to appreciate Dr. Ranga joined and gave the feedback. Anuruddha sir,
thank you very much, Manjula and Ranga and Gobi, for the contributions. We truly appreciate. And it was a very good discussion, I think. Hope everyone learned a lot and enjoyed it.
Yes, sir. The next one, last one, the next Uromet will be the last Uromet before your exam.
Yes.
This will be on BPH and andrology, shared by Ajit sir and Dr. Niroshan Serevaratna. Dr. Trina will coordinate with them and organize that. Then the Tuesday will be the exam. So only feedback is be confident. We all know the facts, and just practice about presenting.
And Gobi, good
yes.
thing, something to be happy about. There we can see clearly there is a good improvement in terms of time handling and the focus answering. So that's a good news for all the candidates. Be confident.
And other thing that this the technology and things are the things very difficult, and but otherwise it is not very difficult. Yeah, this ESWL and all this.
But they did well, no, Manjula?
Yeah.
Yes.
The difficult one they did well.
That's right.
But that's what I want to tell. I shared one video about MRI scan of the prostate, the basic MRI scan of the prostate. It's in the trainees forum. If you go through, just you can get some idea.
Yeah, the technology station is difficult for everyone, even UK candidates. So don't worry about it, because we prepare less on that station, because we are not exposed. We only expose the clinical stuff. So don't worry, we can do it. So Tirina, you can wind up the session.
Yeah. So so that concludes our Uromet 19, and as Dr. Balagopi mentioned, thank you very much once again, Dr. Manjula Herath. You have prepared much more than the candidates, I think, with very good scenarios, and we all learned a lot due to your scenarios. And Dr. Ranga also for your valuable contributions. And as usual, Dr. Balagopi for coordinating everything, and then your valuable inputs, and Anuruddha sir as well. So that is the end of Uromet 19, and good night, everyone, and we'll meet you next time with the last Uromet before the exam. Good night, and have a good time studying.
Okay, good
Good
night.
night. Thank you very much for